ขอสลับเซกชันนิดนึงนะครับเอาเป็นCPET นะครับ we have a great opportunity yeah for the okay Professor Cooper Christopher B Cooper from UCLA America today lecture CPET for COPD evaluation.
All right. Well, again, at this point, I've been asked to speak about cardiopulmonary exercise testing for COPD evaluation, and I will approach this by presenting a little, first of all, about the pathophysiology. Here's my disclosures, actually. That in a COPD presentation, it is important that I should tell you that I have worked with industry, in particular with GlaxoSmithKline. I worked as a global medical expert for GSK between 2016 and 2019. I also work as a consultant for other companies, including AstraZeneca and Chiesi. Those I think are the disclosures that are relevant today to this presentation. So I'm going to talk about the pathophysiology of exercise limitation in COPD, the normal ventilatory response and the concept of ventilatory limitation, what this means and what could potentially happen in our COPD patients, especially when they develop dynamic hyperinflation and deconditioning. I'm going to talk about the ventilatory efficiency slope, how we interpret that in terms of the response to incremental exercise, and we'll talk about failure of oxygenation and ventilatory failure, how we recognize these issues and address them when we're doing cardiopulmonary exercise testing in COPD. So first of all, the pathophysiology of COPD, we can think of this coupling, first described by Carl Wasserman, whereby the lungs exchange oxygen and carbon dioxide with the environment, oxygen uptake, carbon dioxide output. This is to match the metabolic needs of the exercising muscle, oxygen consumption, and carbon dioxide production. And hopefully these are matched by increases in ventilation during exercise. The circulation is important in transporting the oxygen to the muscle and transporting the CO2 to the lungs. And we can have a number of different problems with COPD. We can have the increased work of breathing from mechanical obstruction. We may have limitation in that patients simply can't increase their ventilation sufficiently during an incremental exercise test to obtain a high VO2 max. But on top of that, we have emphysema destroying the pulmonary capillary bed and impairing gas exchange. We have problems with the pulmonary vasculature, pulmonary hypertension, reduced pulmonary vascular conductance due to pulmonary vascular remodeling. We might have left ventricular dysfunction for a variety of mechanical or ischemic reasons. And then finally, in the muscles themselves, we can have deconditioning, which means that the muscles are unable to use oxygen efficiently and develop a lactic acidosis at low work rates. So we will bear all of that in mind when we come to looking at the cardiopulmonary exercise test responses. Now, also it's important to know that physical activity, the maintenance of physical activity is important for survival in COPD. So this study divided COPD patients into 4 quartiles based on levels of physical activity measured with triaxial accelerometers, and the patients with the lowest quartile of physical activity had the poorest survival over the course of more than 5 years. So maintaining physical activity is important, but also having a high aerobic capacity is important, the ability to exercise to a higher level. This could be measured using a simple scale which is called the Veterans Specific Activity Questionnaire. This was developed and used by Jonathan Myers from the University of California in San Francisco, and it is a scale of self-reported aerobic capacity that can be divided into 3 domains. There's the high exercise capacity domain, more than 8 METs. MET is a multiple of resting metabolic rate. There is the intermediate domain of 5 to 8 METs, and there's the low intensity or aerobic capacity domain of less than 5 METs. And you can see that in a variety of different disease states, including COPD, that the higher the exercise capacity, the self-reported aerobic capacity, the lower the risk of death. Or putting it another way, if you have a low aerobic capacity, you have a higher risk of death. And this is not only true in COPD, it's true in hypertension, diabetes, apparently healthy smokers, people who are obese. And if we look at specifically at measured aerobic capacity, this is a study from Japan, some years old now, again dividing the patients into quartiles based on measured peak oxygen consumption. And you can see that the proportion surviving is lowest in the people who had the lowest measured VO2 max during this study. So when we do an incremental exercise test in a COPD patient, we expect to see a non-linear increase in ventilation with respect to increasing oxygen uptake. The increasing oxygen uptake, of course, is expected to be linear because we're creating a linear increase in work rate on the treadmill ergometer. Now we'll talk about the maximum ventilation that's achieved in a moment, but the steepness of this response can be understood by rearrangement of the Bohr equation. The Bohr equation is an equation that links ventilation to oxygen uptake with these terms. The respiratory exchange ratio, that's the ratio of carbon dioxide output to oxygen uptake, expressed breath by breath. There's the arterial partial pressure of CO2, where we choose to regulate our PCO2. Is that 40 or is it 30? And the efficiency of ventilation in terms of the dead space to tidal volume ratio. Actually, you can say that this is a metabolic term, a control term, and a ventilatory efficiency term. And you can see that 3 things could make this response steeper and push the patient up to higher levels of ventilation at a given oxygen uptake. One would be a high R value. We see that when there is extra carbon dioxide coming from bicarbonate buffering of lactic acid. So we'll come back to this, but deconditioning increases the steepness of this response. Regulating our PCO2 lower, in other words, having inappropriate hyperventilation. If I'm a COPD patient and I choose to regulate my PCO2 at 30 as opposed to 40, I have to have a higher level of ventilation. That might be a pink and puffing patient as opposed to a blue and bloated patient. And then finally, if I have a high VDVT, this fraction becomes smaller and the slope becomes steeper, which makes sense because high VDVT means less efficient ventilation, more dead space or wasted ventilation, and therefore the total ventilation has to be higher at a given level of oxygen uptake or at a given work rate. Now, it's of interest to know what is the maximum ventilation that an individual could achieve during a cardiopulmonary exercise test. Well, it's difficult to measure. At rest, we can do this by doing a maximum voluntary ventilation maneuver. It's simple spirometry, where the patient is asked to breathe as deeply and fast as possible, just for 12 seconds. We can only do this for 12 seconds because it is voluntary hyperventilation, and it will cause the patients to get hypocapnia and respiratory alkalosis, and they may have the associated symptoms, including syncope associated with hypocapnia. So we just do it for 12 seconds. We measure the ventilation over 12 seconds. We multiply this by 5 to get 60 seconds, and we have what's called a maximum voluntary ventilation. Now, if we assume that in every minute we spend 20 seconds breathing in and 40 seconds breathing out, in other words, the I to E ratio is 1 to 2, which is approximately correct, then we could reason that in 40 seconds, the most we can breathe out in 1 second is the FEV1, so the most we could breathe out in 40 seconds is the FEV1 multiplied by 40. Therefore, it's reasonable, and we do actually find that 40 times the FEV1 corresponds quite well with the maximum voluntary ventilation. So if you want to understand your patient's ventilatory capacity, you can do 3 things. You can measure an MVV before your cardiopulmonary exercise test. That's the ideal, in my opinion. Having said that, bear in mind, maximum voluntary hyperventilation is not quite the same as ventilation during exercise. But that's the best way to know the ventilatory capacity. Say, for example, the patient achieved a ventilation level of 160 liters per minute. You would then be interested to know, when they did an exercise test, at the end of the exercise test, whether their ventilation also reached 160 liters per minute. It's not likely to be more, but could it be less? And if so, could they have increased their ventilation more during exercise? And were they limited by other factors? A second approach is, if you don't measure MVV, you could measure FEV1 in your patient and multiply by 40. Those of you who are familiar with cardiopulmonary exercise testing will know that some people advocate multiplying by 35. Given what I've explained here, you'll know that just makes the assumption that you spend 25 seconds breathing in and 35 seconds breathing out. But if you have neither of these measurements, you could look at a reference value, for example, from the Global Lungs Initiative for your patient, and multiply that by 40 to get a maximum voluntary ventilation. But that would assume that the person had normal lung function. We were interested in the maximum voluntary ventilation maneuver and how it was best performed. What we typically find when we instruct patients to breathe as quickly and deeply as possible for 12 seconds, they can usually hit a breathing frequency of around 70 per minute. We took some healthy volunteers and measured maximum voluntary ventilation for a variety of breathing frequencies paced by a metronome. And we found actually that the highest MVV was achieved when we paced the subjects and tell them to breathe with an audible signal at 100 breaths per minute. It turns out that the patients achieve about 97% of the maximal value with self-paced breathing at about 70 breaths per minute. So something in between 70 and 100 breaths per minute is ideal for measuring maximum voluntary ventilation. And what do we find in our lab? With a large database of normal subjects, we find that the maximum exercise ventilation is only 55% of NVV, or ventilatory capacity, in men, and only 50% in women. So in our normal database, people are only using just over a half of their ventilatory capacity at maximum exercise. And that is what we might expect. Now, what happens with COPD? Well, let's think now about the concept of ventilatory limitation. We have the same relationship between ventilation and oxygen uptake, but whereas the ventilatory capacity in a normal subject might be, 140, 160 liters per minute, in severe COPD it's going to be reduced. And if it's reduced, even if we had a normal ventilatory response, we're not going to get to the same level of ventilation, and we're not going to have as high of a VO2 max at the end of the incremental exercise test. The patient will have to stop when they reach their ventilatory capacity. Well, if we have ventilatory limitation so described, then it really matters whether the ventilatory response is normal, whether it's steeper, or whether it's more shallow. Because, again, remember, things that make this steeper, like deconditioning, hyperventilation, and high VDVT would all force the patient to reach their ventilatory capacity at a lower level of oxygen uptake. And one of the things that's, of course, we can impact, or we can impact two things in COPD patients. We can impact deconditioning by having an exercise training program or a pulmonary rehabilitation program, reduce the excess CO2, reduce R, and make this more shallow. We can give patients breathing retraining to discourage them from hyperventilation and help them regulate their PCO2 at a more normal level. And that would lower the slope of this response and therefore allow them a higher maximum oxygen uptake. Once VDVT is disturbed by the inherent lung disease, obstructive or restrictive, it's quite difficult to change that. We hope that when people exercise, they get more uniform distribution of blood throughout the lungs, and that lowers VDVT. It's a normal response, but the ability to do that will be limited when you have people with chronic lung disease. So here's the concept of ventilatory limitation, which we might see in some COPD patients, but in the literature, when COPD patients are tested, over a wide range of severities, only about half of the subjects will actually have ventilatory limitation in these terms. It's not inevitable, even if you have some of the underlying pathophysiology. But I use this slide to illustrate that you can predict maximum exercise ventilation. These data, that is the ventilation level you measure at the end of the incremental exercise test, and it can be predicted in 3 different published series by 20 times the FEV1 plus 20. The ventilatory capacity could be predicted by 40 times the FEV1 or 35 times the FEV1. Let's say 40 times the FEV1. Now, if we have an FEV1 of 2.5 liters, the ventilatory capacity is 100 liters, and the maximum exercise ventilation would be 50 plus 20 or 70. A person would use 70% of their ventilatory capacity. But if we have lung disease that reduces FEV1 to 1 litre, the ventilatory capacity would now be 40 litres per minute, and the maximum exercise ventilation we would predict it also being 40 litres per minute. So we can use this reasoning to anticipate that once people have an FEV1 as low as 1 litre per minute, it is highly likely, we could almost say inevitable, that they would have ventilatory limitation. And that's something to look out for during a cardiopulmonary exercise test. Now, the other thing that we are interested in terms of the ventilatory response during incremental exercise is the so-called ventilatory efficiency slope, because when you plot ventilation against CO2 output, and this is a better relationship to study because ventilation is mainly coupled to CO2 output, you see a nice linear relationship and then an inflection point. For the whole of the first part of the cardiopulmonary exercise test, ventilation is coupled to CO2. It is a mechanism controlled by the central chemoreceptor in the brain. And it also includes the phase where we're getting CO2 not only from aerobic muscle metabolism, but also from bicarbonate buffering of lactic acid. The central chemoreceptor doesn't care where the CO2 comes from, it continues to regulate ventilation according to the CO2 that needs to be excreted. Until the point where we exhaust or overcome or overwhelm the bicarbonate buffering capacity of the blood. And then you have unbuffered hydrogen ion in the blood stimulating the carotid body and driving up ventilation by a different mechanism through the peripheral chemoreceptors. That is independent of central chemoreceptor control, and it uncouples ventilation from CO2 output and creates this very clear inflection that you can so readily see when you do a cardiopulmonary exercise test, not only in normal subjects but also in people with disease. So, ventilatory limitation, going back to that, is defined in our laboratory when the maximum exercise ventilation is within 15 litres per minute of the ventilatory capacity. That's a criterion that has been laid down in the literature, first advocated by Carl Wasserman and his colleagues. But we don't take that alone as a criterion, because we want to see that it is also a high percentage of ventilatory capacity. Why do I say that? Well, for example, if your subject had a ventilatory capacity of 40 litres per minute, 25 litres per minute would be reaching that single criterion for ventilatory limitation, and yet I think it's only just half of the patient's ventilatory capacity. We would rather see that it was within 15 litres per minute and within 15%. So, it would be something like 36 litres per minute is what we would call ventilatory capacity. Ventilatory limitation in that subject with a ventilatory capacity of 40 litres per minute. And one of the things you can say when you see this inflection point is the person has pushed themselves to the point that they have sufficient lactic acidosis that they've overwhelmed the bicarbonate buffering capacity of the blood. If you don't see this, you can't say that that happened, and it probably means that the subject didn't give a sufficient effort, or they were limited by some other factor. If we see it, as I say, we know that there has been a sufficient effort to generate that amount of lactic acidosis. We can use a simple schematic then to interpret the ventilatory response in terms of whether or not a person reaches their ventilatory limitation. whether they have a normal slope response or exaggerated or attenuated, and that we can look at end exercise ventilation and decide whether they have a high or a low ventilatory requirement for exercise. Those are the things we look for in cardiac pulmonary exercise testing in COPD. Now, one of the central mechanisms, pathophysiology mechanisms in COPD during exercise is this dynamic hyperinflation. And we've seen similar slides earlier this morning that illustrate, first of all, static hyperinflation means that residual volume, FRC, and total lung capacity are all increased with obstructive lung disease. TLC is increased to some extent, FRC is increased more, and RV is increased the most. That's the classic pattern of hyperinflation or static hyperinflation. But when people exercise and they increase their breathing frequency and they have a shorter time for exhalation, they can't exhale all the air that they breathe in a single breath, and so the end expiratory lung volume creeps up during exercise. This is called dynamic hyperinflation, and it reduces the difference between end expiratory lung volume and total lung capacity. We call that the inspiratory capacity. So the inspiratory capacity is reduced with progressive exercise in COPD, and it's worth thinking about this and actually looking for it when you're doing cardiac pulmonary exercise testing in COPD patients. What it means, and again you've seen similar slides, this is a normal subject where tidal volume increases during exercise by virtue of lowering FRC or end expiratory lung volume and increasing end inspiratory lung volume. And the tidal volume range or the operational lung volumes remain on a steep part of the respiratory system compliance curve, meaning that for given intrathoracic pressure changes, you get big and satisfying changes in tidal volume. But with COPD, where there is dynamic hyperinflation, what is happening is we're pushing the operational lung volumes up onto a flatter part of the compliance curve. This requires much greater pressure swings in the thorax to generate given changes in volume. And the elastic work of breathing is significantly increased. This is what causes dyspnea. And in fact, static hyperinflation gets worse with worsening spirometrically defined COPD. So as the FEV1 as a percent predicted falls, the RV as a percentage of total lung capacity increases. That's quite well known. So the static hyperinflation gets worse, and dynamic hyperinflation gets worse as well. With this air trapping and hyperinflation, it's driven by things that like deconditioning is associated with ventilatory limitation, and the hyperinflation has strong associations with patient-reported outcomes like breathlessness, activity limitation, and health status. Much stronger associations than between hyperinflation and FEV1. So another thing that can cause worsening air trapping and hyperinflation is anything that increases breathing frequency, such as hypoxemia stimulating the carotid bodies, or anxiety causing the patient to increase their breathing frequency. All of this can worsen air trapping and hyperinflation and impact dyspnea, activity limitation, and health status. And the purple boxes, in a way, are the potential targets for making this situation better. Reconditioning exercise will lessen ventilatory requirement. Preventing exacerbations, because exacerbations worsen this. Giving patients supplemental oxygen to prevent hypoxemia stimulating the chronobody, giving patients breathing retraining exercises to avoid tachypnea. As you can recognize, these are all essential features of a pulmonary rehabilitation program. So when we do cardiopulmonary exercise testing in COPD, we can measure these things, we can see which is most impactful in a given patient, and we can tailor their pulmonary rehabilitation program accordingly. Now, we have shown that sometimes it's difficult in a research context to study dynamic hyperinflation with cardiopulmonary exercise testing, particularly at multiple clinical sites. So we've developed a methodology which we call metronome-paced tachypnea. It's more and more people are interested in this nowadays, and what we found is all you need to do is have your subject breathe at 20, 30 or 40 breaths per minute for 30 seconds, and you get a big change in inspiratory capacity, a reduction. And in fact, we've opted for pacing with a metronome at 40 breaths per minute for 30 seconds, and we can anticipate changes in inspiratory capacity of several hundred milliliters. You can see here 400 mils on average for that simple maneuver, and it can be done 3 times with rest periods over the course of 10 minutes, and you've got a very good measurement of dynamic hyperinflation. And dynamic hyperinflation happens not just in severe COPD. Dennis O'Donnell's group have shown that it can happen in patients, as you can see here, whose FEV1 values are actually normal, but they have airflow obstruction, as demonstrated by an FEV1 FVC ratio of less than 70%. And if you compare these with age and sex max controls, you can see that these individuals, they have falls in inspiratory capacity with increasing work rate. And along with that fall in inspiratory capacity, inversely, their inspiratory reserve volume, the difference between end inspiratory lung volume and total lung capacity, that difference, we're plotting it as a percent of TLC. So you get closer to TLC more quickly if you have airflow obstruction than if you did not. This is the inspiratory reserve volume. And we know, again, dynamic hyperinflation manifests by an increase in FRC over TLC at maximum exercise, happens even in patients with mild to moderate COPD. In this series by Tony Babb, patients with mild COPD who had reduced VO2 max 69% predicted, had evidence of dynamic hyperinflation during exercise. This is a really important study by Dennis O'Donnell's group. It shows for constant load exercise at 75% of maximum work rate. These are the resting lung volume range from end inspiratory lung volume to end expiratory lung volume. End expiratory lung volume increases with exercise. That's dynamic hyperinflation. But also end inspiratory lung volume increases, reducing inspiratory reserve volume. And Dennis O'Donnell has plotted inspiratory reserve volume against breathlessness in a beautiful study that shows breathlessness increases, but once your ILV gets less than 500 mils, breathlessness increases markedly. This is going up on that flat part of the compliance curve, the elastic work of breathing. So it's predictable when ILV is less than 500 mils that the patients will have intolerable dyspnea, and that will likely stop an incremental exercise test. This is one of the ways in which bronchodilators improve exercise capacity in COPD. If you want to test before and after inhaled bronchodilators. Bronchodilators, first of all, are a very effective way at reducing static hyperinflation. So if we compare in green a group of patients taking tiotropium, a long-acting muscarinic antagonist, with those on placebo. Those on tiotropium have less dynamic, have less static hyperinflation. So when they exercise, yet they still have increases in end expiratory lung volume. So there's still some degree of dynamic hyperinflation, but it is less consequences, and the IRV is preserved for longer. So you have increased endurance time and an increase in inspiratory capacity when you give patients with COPD inhaled bronchodilators. The cardiopulmonary exercise test, at least that type of test I've just shown you, the constant load test for endurance time, is the most sensitive way of detecting improvements in COPD patients with an intervention. Like inhaled bronchodilators, this was actually performed by Oger with oxytropium, a short-acting muscarinic antagonist. But you can see the 6-minute walking test is the worst test to demonstrate any improvement when you give inhaled bronchodilators. Maximal exercise tests with measurement of work rate, oxygen uptake, CO2 output, and ventilation show some ability to detect improvement, but the constant load test on a cycle is by far the most effective. And I think the FDA is on the point of accepting endurance exercise tests on a cyclodrometer as a valid endpoint for clinical trials in COPD going forward. Now, how do we recognize dynamic hyperinflation during a cardiopulmonary exercise test? Well, we start off at the beginning of the test by doing a maximal inspiratory and expiratory flow volume maneuver. And you'll recognize this outer envelope, the gray line is the maximal flow volume loop at rest. Its expiratory limb is concave, consistent with an obstructive patient. The inspiratory limb is relatively normal. And then the red loops are the flow volume loops that can be captured during an incremental exercise test. So every 2 minutes during a test, and your equipment will allow you to do this, you switch to an intra-breath IC maneuver. You can watch the tidal flow volume curves like this, and then you can say to the patient, on your next breath, breathe all the way in to total lung capacity. That sets the tidal flow loops on the x-axis and allows you to see what has happened to end expiratory lung volume. Because remember, on these curves we have TLC and RV, end inspiratory lung volume and end expiratory lung volume. Now you can see that as this patient goes to higher and higher levels of work rate, first of all, the tidal flow loops, they have a concavity or even exceed the maximal expiratory flow volume loops, but more importantly, here the end expiratory lung volume is shifted to the left-hand side because you can't increase the tidal flow loops down at this end. The range of capable flow is so limited, so everything has to get shifted over to here, and this was close to maximum work rate, where the patient has clear expiratory flow limitation and dynamic hyperinflation. Now the same patient, this is the same patient, doesn't necessarily have to have ventilatory limitation. In this case, the maximum ventilation is, I think, 74 per minute, or 68 per minute, but the ventilatory capacity in this patient was over 100 liters per minute, so there was not ventilatory limitation. You can see there was lactic acidosis, but you can have dynamic hyperinflation without necessarily having ventilatory limitation. And this person and didn't have cardiovascular limitation either because they were limited by intolerable breathlessness from the dynamic hyperinflation. Deconditioning, I've more or less described the vicious cycle of breathlessness, decreases exercise capacity, which leads to physical deconditioning, that increases ventilatory requirement through lactic acidosis. It's a vicious cycle, and it reduces aerobic capacity. Pulmonary rehabilitation can correct that vicious cycle by reconditioning exercise, decreasing ventilatory requirement, decreasing breathlessness, increasing exercise capacity. So the impact of deconditioning on the cardiopulmonary exercise test response can be quite easily seen with a low lactate threshold and low VO2 max. Ventilatory efficiency I talked about earlier, this lower slope. It has two factors that influence it. From the Bohr equation, one is the PaCO2 and one is the VDVT, and we talked about that earlier. But things that increase the steepness of this response are low PaCO2 and a high VDVT. Now, the normal ventilatory efficiency slope is in the range of 25 to 30. If the subjects are under the age of 50, we allow it to be a little higher, 30 to 35 in older subjects. And remember the formula that relates ventilation to CO2 output. So when we examine the ventilatory response during cardiopulmonary exercise test, we think about these things. If there's a serious gas exchange abnormality, VDVT, we'll see the impact on this relationship. And if there's hyperventilation that is inappropriate, we'll also see that. Now, why is this important? Well, it turns out that ventilatory efficiency slope is higher in patients with heart failure. And it's a powerful predictor of death in patients with heart failure. As you can see, this upper plot, high or low VeVCO2 slope is associated with different survival. And it's a better predictor of death than VO2 max even in patients with heart failure. Now the modeling, mathematical modeling suggests that the mechanism that is responsible for the increase in this slope is more likely to be an increase in VDVT than a decrease in PaCO2. You can have a small decrease in PaCO2 with heart failure associated with tachypnea, but the changes in PCO2 are so small they're not sufficient to account for the marked changes we see in this ventilatory efficiency slope. So it's VDVT that's the problem. And how does that come about in heart failure? Well, I think the raised left atrial pressure, the stiffness of the pulmonary vasculature, and the development of pulmonary edema are all factors that impact tidal volume and increase VDVT. Now, we should be concerned about oxygenation when we do cardiopulmonary exercise testing in patients with COPD, and in fact, we might want to know who's going to desaturate when they exercise. Well, this is predictable based on the degree of emphysema primarily, but also based on FEV1 and baseline oxygen saturation when you start. But that's not surprising. The worse the FEV1, and particularly the worse the emphysema, the more likely the patient is going to desaturate when you exercise them. So is this a problem? It could stop the exercise test. And then you'll end up concluding that the patient was limited by desaturation. Now you may not want that to happen. You may still want to exercise or tests evaluate the patient's cardiorespiratory function, try to push them to the highest possible heart rate or ventilation without being worried about desaturation. And in order to do that, we use a technique of using a higher inspired oxygen concentration. This diagram is from Jerry Kreiner's publication related to the National Emphysema Treatment Trial. These were patients with severe emphysema who we tested before and after lung volume reduction surgery. But to prevent them from desaturating, we had this set up with a blender, so you have an air and oxygen supply either from the wall supply or from cylinders going into a blender, and then the blender creates a predetermined concentration of oxygen. For this study, we chose 30%. And then we have patients breathing through a closed system. You can't have a system like nasal cannula, the low flow system where patients are in training room air. You have to have a closed system where you know that the entire air volume that they're inhaling has a predetermined oxygen concentration. And providing this concentration is less than 50%, your metabolic measurement system should be able to calculate all the parameters, ventilation, oxygen uptake, even if you wanted to draw arterial blood gases, you could calculate alveolar arterial oxygen gradient, knowing that there was a higher inspired oxygen concentration. So this is a technique to use. I would recommend if you're testing COPD patients, if you're doing CPET in COPD patients who are going to desaturate. And then finally, there are occasional patients who have ventilatory failure. Rather than hyperventilating during exercise, they just can't achieve an adequate alveolar ventilation, and their arterial and then tidal PCO2s rise even higher than 50 millimeters of mercury sometimes. And this is a fairly rare occurrence, but it is something that you need to recognize occasionally in some patients, and it's going to impact their exercise ability because with rises in PCO2, as shown for this particular patient, there were falls, more profound falls in bicarbonate, in other words, more of a respiratory acidosis, and that would eventually impact their exercise performance. Why do people get worsening partial pressures of CO2, ventilatory failure during exercise? This data from Dennis O'Donnell suggests that it's the increase in PCO2 is related to the dynamic hyperinflation, that by elevating the end expiratory lung volumes, you're restricting the ability to increase alveolar ventilation, and then that in itself causes the worsening hypercapnia. So I've reviewed the pathophysiology from various aspects, talked about a number of technical issues in cardiopulmonary exercise testing in COPD, and given some examples of what you can expect related to the underlying pathophysiology. So thank you so much for your attention. If there's time, I'll be happy to answer questions.
Thank you so much, Professor. ตบมือให้ Professor นิดนึงนะครับ We have a lot of technician and doctor here. This pulmonary rehabilitation technician.
Yes.
Yeah. I have one question for you. You mentioned about dynamic hyperinflation in the key points of this in COPD patient, right? So if we have bronchodilatation like tiotropium, the decrease the dynamic hyperinflation, a patient can improve the dyspnea or dynamic hyperinflation. If we use another bronchodilator, like short-acting bronchodilator, like albuterol or albuterol
Yeah.
before exercise. How do you think about this? Instead of tiotropium?
Well, you can certainly, again, I think when you perform an exercise test, it's like the oxygen question. What do you want to test? You know, do you want to test the person's exercise performance with regular inhaled bronchodilator therapy? So you might want to make sure that they have maximal bronchodilation before you test them. Let me rephrase that. The question would be, what's the best exercise performance with maximal bronchodilation? So you could give them bronchodilators before the exercise test. That wouldn't be a bad thing to do at all. You have to bear in mind that the beta agonists, particularly albuterol, are likely to cause an increase in heart rate, and you'll see that in the cardiovascular response. So it will slightly complicate the interpretation of the results in that respect. But, you know, if you have a patient who's either not been prescribed inhaled bronchodilators and has exercise limitation, or they're not taking their inhalers, and you want to see what exactly is limiting their exercise performance, and you want to demonstrate very clearly that they have dynamic hyperinflation, you might want to do the exercise test without giving a bronchodilator beforehand. Or you could do both. I mean, it's a choice. Yes.
Thank you so much. Do you have any questions from the audience? Dr. Chichia, again, my residence, first year residence.
So basically, like you actually mentioned the way to measure the ventilatory capacity, correct? Like there are 3 ways, and you also mentioned that you prefer the maximum voluntary. Yeah. Can you explain again why you prefer that way?
Well, I think the reason is that the calculations of ventilatory capacity from single FEV1 maneuver, they're estimations really. They're not a direct measurement, and they may or may not be correct, depending on whether or not the FEV1 measurement is correct. But if you actually get the patient to breathe at the highest level of ventilation for 12 seconds, say it is 140 liters per minute, you know for sure that that patient can move air in and out at a rate of 140 liters per minute. So when you do the exercise test, you know, if they get to that point, 140 liters per minute, you can say, oh, I'm pretty sure this is ventilatory limitation. Or if they don't get to that point, say they stop with an exercise ventilation of 100 liters per minute, the ventilatory reserve between ventilatory capacity and maximum exercise ventilation is 40 liters per minute, and you can say, well, it wasn't the ventilation that stopped this patient. I know because of my MVV maneuver that they could have gone higher. So that's why I think to measure it directly is better than taking an estimation based on assumptions.
In Thammasat University Hospital, we have a protocol. We do MVV maneuver before spirometry first or MVV first, and then go to CPET test.
Yes.
Yeah.
Well, I think you saw this in practice at UCLA, right, when you spent time with us there. So we do that always.
Do you have any question? Professor Prabhapon from Ramath Hospital, Mahidol University.
Thank you. Thank you for being here.
My question is, when you mention about the dynamic hyperinflation during exercise, you measure the inspiratory capacity intermittently with the inspiratory capacity drop is that mean the dynamic hyperventilation happen at that point? Is there any way to measure like another way to measure because sometimes the IC maneuver is not done at the end of an expiratory lung volume. So
yeah, you there's a technique to doing this, and the equipment that you use can allow you to switch to a screen that shows spirometry like this. So it shows the tidal volumes like this. And what we do is we wait to see that there have been 1, 2, 3 tidal volumes that are all pretty consistent. Because end extracorporeal lung volume can vary a little bit. You don't want it to vary a lot before you do this maneuver because you don't really know what the baseline is. But if you can see that the end expiratory lung volume is pretty steady, when you see that happening, and you can coach the patients, you practice it at rest before you start the exercise test, so the patients understand what is expected of them. And then you say, very specifically, these words, on your next breath. You don't look at the spirogram and try to say, breathe now, because the likelihood is you catch them at the wrong point in the tidal breathing. You say to them, on your next breath. So they do another normal tidal volume, and they themselves go to total lung capacity. And you can see the spirogram. It's nice and regular, and then it goes up to inspiratory capacity. And you say, on your next breath, take a full breath to fill your lungs completely. And when you get there, just hold for a moment. So you see the little plateau. And then back to normal breathing. And it takes less than 10 seconds. And so you can do that every 2 minutes. 2 minutes is often when we take blood or, it's not too frequent to be too difficult for the technical aspects, and it's not too infrequent to give insufficient information. So every 2 minutes is about right. Now, it's more important to see what's going on during the 10-minute test than at the very end, because trying to do this at the very end of the test, when the patient is most short of breath, when they're about to stop, and they've got fatigue, and you're probably not going to get a very good measurement at the very end of the test. So you'll have to rely on the measurements that went before that to know whether or not the person is developing dynamic hyperinflation.
Thank you so much. ตบมือให้โปรเฟสเซอร์อีกรอบหนึ่งนะครับ ขอบคุณมากนะครับ You have a lot of experience in CPET test.